coming here. I am so thrilled to see the young people in the audience. So this is a session which should give us a chance for all of you to ask questions, to give feedback to two experts whose job it is to interact with the public and to take our concerns forward. I'm Lisa Primate, and I work as an internist and a geriatrician in Seattle. I am honored to be the Washington State Director of Doctors for America for the past 3 years now. I felt compelled to work for social justice from an early age. History of my activism, I would say, goes back to my age of 15, when my family moved from Arizona to Silver Spring, Maryland, in the DC area, and I was able to participate in the March on Washington and hear Martin Luther King's I Have a Dream speech. So that tells you how old I am. That inspiration, plus my love for biology, drove me into medicine as a career. In medical school, I was dismayed by the separation of our clinic patients from the private patients. And then after 30 plus years of practice, I've watched the disparities between the haves and have-nots widen. I know that we can do better. My first job when we went to Seattle 5 years ago was working with migrant workers in Eastern Washington in a community clinic. I commuted over the mountains for 3 hours, a week a month. My current, and that certainly was an eye-opener, even more than my previous jobs had been. And currently I work in a clinic in the inner city of Seattle in an area that I would say, I'm proud to say, is the most diverse zip code in the United States, in a federally funded clinic through CMS. Basically, I'm working in a hotspot in which 99% of our participants are very poor, very frail, very poor elderly. Throughout my career, I watched the corporate takeover of our healthcare system with dismay and anger. When we finally got a president who put healthcare at the front of his agenda, I knew I had to join in. I soon learned of DFA, and honestly I can say I found a home. Here was a grassroots movement of diverse doctors across specialties and across geographic regions and across ages who believed above all in advocating for patients, dedicated to overhauling our system until everyone in America has access to affordable and high-quality health care. I would say, above all, that DFA empowers me to magnify my voice as a patient advocate and to have it heard. Yes, it's true, we learn at this meeting that what we do is we network, we brainstorm, we learn, we educate, we partner. But there's something power in coming to a community as a representative of this organization. In Washington State over the past year, because of DFA, our members have met with regional HHS directors soliciting public input on the benefits package. We've worked actively with the Healthy Washington Coalition with a number of community partners to develop a fair exchange, which was signed into law by our governor this past month. Hooray, hooray. I've served on a state commission to assure low-income Washingtonians have access to care. We're forming a coalition across primary care, with family practice, internal medicine, and pediatrics. And our first focus is on trying to get the two gubernatorial candidates, one of whom has signed the lawsuit against the Affordable Care Act, to participate in a health care exchange and a forum. So far we haven't been successful, but we're still working on it, and we will get at least those two people there. We've had numerous house meetings, panels, worked with medical students, internal medicine residents in the new public policy track at the University of Washington. And I can also say that with DFA, I'm very proud that we wrote our Occupy Healthcare manifesto this past year. In short, there's so many ways that you can plug into the action in DFA. We need everybody working, and you can pick and choose from a vast menu of things to do. Our system will change because it has to. The question is, will we as physicians be there to determine how it changes? And I'm very pleased to introduce our two speakers today. One of whom I know very well, and the other of whom I'm very pleased to meet. Mandy Cohen, many of you know, was our former executive director at Doctors for America. And she is now working she continues to work as an internist. She's also director of stakeholder engagement for the Center for Innovation at CMS, the Center for Medicare and Medicaid Services. In that capacity, she oversees external communication and works with their many constituencies to identify and test new payment and care models. So it's not a small task. When Mandy was the head of Doctors for America, the executive director, I so well remember, and I'm sure many of you do, it was almost like fireside chats that we had on a weekly basis on policy, especially in such an exciting time as the time leading to the passage of the Affordable Care Act. We really felt like we had our hand on the pulse of what was going on in DC because of her wonderful, insightful comments. She currently works also as an internist seeing patients at the Washington VA, where she led an initiative to improve the delivery of primary care for women veterans. Mandy obtained her MD from Yale, her MPH from Harvard, and did her internal medicine residency at Massachusetts General Hospital. Thank you so much for being here, Mandy. And our second speaker, who comes to us directly from the White House, is Mr. John Carson, who's the director of the Office of Public Engagement for the White House. So now, I didn't know much about this public engagement thing, and I had to wrap my head around this, but it seems to me that they're both doing the same kind of thing, only representing different agencies, but they're both responsible for interaction with the public on what's going on. I think John has a much broader position. It's not just healthcare, but healthcare is one of the things he's in charge of, and Mandy, of course, is specializing in healthcare aspects. Previously, Mr. Carson was the Chief of Staff at the White House Council on Environmental Quality, which is important for healthcare as well. Before he joined the administration, he was the National Field Director for President Obama's campaign in 2008, and he worked on the Obama transition team. He worked on several earlier campaigns going back to Al Gore's 2000 campaign, and possibly some earlier ones, but that's one of the primary ones. He had served in the Peace Corps in Honduras for 2 years, where he helped build water systems for rural villages. He graduated from the University of Wisconsin in Civil and Environmental Engineering and has a master's in geography from UCLA. Thank you so much for being here.
All right, so we have a couple of mics that will be roaming around the room. This is basically open question this season. So actually, might start with a question for the two of you, just to kind of set the stage of, in the work that you do, what is it that you want to know from doctors?
Thank you, Allison, and thanks, Lisa, as well. I'll start out. I would love to hear more about the conversations that you are having on the ground all across the country. And first of all, let me just start by saying thank you for the incredible work Doctors for America does. I work with a lot of different advocacy groups, and you are among the most effective voices that we have in this fight. I'd be happy to give you lots of examples of that. In fact, I was talking with Vivek. I'd love to take you to some other issue areas and have you give them some lessons. But I'd love to hear your stories about what works. What helps you convince that other colleague to be an advocate for healthcare? What works with that group that you're talking to locally to help turn them into one more part of your 1 million campaign? I'd like to hear what's working for you.
Well, I should let testing out new service delivery and payment models. Because we all know, and I'm sure you've talked about all morning, is the costs are unsustainable, but we know we can do better. I think all of us in our practice know that there are inefficiencies in the system, there are unnecessary costs, that we can do better for our patients and do it for less. That's a really hard conversation to have with the whole country. That means a lot of change for a lot of people, and change is scary. So I think I'm happy through the course of our questions and conversations to let you know about some of the work that we're doing and what makes the Innovation Center unique and a really exciting opportunity that I hope you all learn more about. But I wanted to hear from you about the conversations that are going on in hospitals and clinics about the fact that we all are going to need to change, whether it's you've been in practice for 30 years or you're just about to enter practice. Medicine's going to be different as we go forward, because we're all going to need to be part of that together. So how do we have a conversation about that within our profession and also with our patients about that? And I think it's really challenging. So I don't know that we'll answer it, but those are the types of things that we think about all the time. How do we engage with the doctor community better to think about the hard part of change that's coming, and how do we do that together so we do it in a thoughtful way?
Hi. Well, in answering your question, I'm with doctors that are in denial about all of that, because I'm at Cornell in New York City, so everybody's head isn't the same. My question relates to the various states around the country, starting with Texas, that have defunded Planned Parenthood, are now losing their Medicaid funding. Thus, women all over the country no longer have providers, and what is being done about that?
Well, I can talk a little bit about the advocacy side on this and the legislative battles that we're in. As you know, as you mentioned, states are taking state-by-state actions, but there's been a massive fight in Congress to directly defund Planned Parenthood. And across 2011 and 2012, that is actually one of the areas I've seen one of the most effective advocacy campaigns. I think the keys to it, because we've won these battles each and every time at the federal level, we now have to deal with these state-by-state efforts. The success has been in that the advocates took it from a national conversation to a local conversation. What does it mean here in Eau Claire, Wisconsin, if we lose this primary health care, this access to preventative care for women in our community? I think no matter what the advocacy issue is you're working on, being able to talk about it locally has been crucial. Second, in an area, and I know Doctors for America has been one of the #1 providers of these local voices, having that local trusted voice has helped in this as well. You probably remember in the first government shutdown fight, it literally went up until the last half hour. It wasn't until 11:30 p.m. On the night before the government shutdown that we had a deal. And one of the last things on the table was defunding Planned Parenthood. But the reception that members of Congress got back home, and that's another key point. Important things happen here in Washington, D.C., but decisions about what matters and what they're paying a political price for doing on the policy front, those judgments come from what happened in their districts. And those members received such a backlash for those proposals in their districts that even though they proposed it again for the next budget, we won that fight very, very quickly. And so what I see happening now in the sort of broader war on women's health care is that coalition getting stronger and stronger. I think where the challenges have actually been the greatest is at the state-by-state level.
And I might just add on the policy level about Medicaid, obviously some influence comes from Washington and CMS with Medicaid, most from at the state level, just to echo John's comments about how important state level engagement is in this kind of activity, because every state is different. But I wanted to talk about some beacons of hope, actually, even in Texas. So we all know that the Medicaid rolls are expanding, but there are some things that we are trying to do to make sure as we expand that we're bringing folks into a system that works. It works both for docs and also for patients. And we know a lot of people don't take Medicaid patients because of, frankly, the funding and reimbursement is so low. And so I know we worked hard when health reform was being passed to make sure that we tried to increase Medicaid reimbursement for primary care, and so while that's not permanent, it will be there for at least 2 years, and again, something that needs to be fought for to continue. But we're also putting in place new tested delivery systems, particularly, actually 2 in Texas, around integrating behavioral health and primary care together in a health home. And Texas is actually one of the states that is exploring it. I was just talking to Evan from Oregon, who's already out in front and doing this, but Texas has actually been considering how they can take advantage of federal matched dollars to bring together primary care and mental health care. So that's a bright spot. They haven't done it yet, but again, a place of potential advocacy at the state level.
I work at an academic medical center, and something people talk about here is that one person's waste is another person's income. So, so in particular, large academic centers depend on discrepancy in that way, a discrepancy in value of price, because that money is then used to cross-subsidize on admission. So you may get overpaid for cardiology, but then that pays for psychiatry. You know, you may overpay for general surgery, but that pays for endocrinology. So part of the thing that's concerning to some people is that as the reimbursement for those specialties may drop, the overall pie gets smaller. So what I was going to ask is, how do you ensure that those cuts then don't disproportionately impact the kinds of services that people depend on, that don't pay as well? Because already, all those people are bearing the brunt of a lot of these types of cuts.
So two answers to that. So we're trying to do some different types of payment models to get at that exactly. I think it happens not just in academic centers, I think it happens in an individual primary care practice. You know, you pick up a few skin tags so you can counsel someone about their obesity that you don't pick up. You know, we know that cost shifting exists. So there's a lot of market failures in there that we need to address. And so where do you begin, right? It's overwhelming. And so we're trying a couple different ways. One of them is a type of payment model called a shared savings model. And that's being used mainly for accountable care organizations, larger integrated systems, where all of the different departments and all the integrated providers within that system have to come together and figure out how to provide the best care for that patient, and only then can they think about reaping rewards from that savings. And then they have to have an internal dialogue about how do you eliminate the cost shift and properly distribute the cost and the reward across services. So that's one. Again, these are all new tests. These are all new ways that we're trying to think about it. The other is that we just know we need to invest in places that are not getting paid well. And if you invest in those, and then on the out years, you sort of decrease that payment over time, we can have that upfront infrastructure investment, and hopefully the cost shift will end in the out years. So we're doing that in primary care in particular. So there's a primary care program that we're working on right now. We're going to invest a ton of money in practices to totally transform themselves. But they're going to have to give us something different in return. It's going to be a different type of service that primary care provider is going to have to do. They can't do skin tag removal anymore. We want them to do real primary care, which is sometimes they can't do when they're in the system. So I think we're trying to get at it in a few different ways. It's a huge problem, but you need to start to tackle it somewhere, and then we'll keep iterating on that theme. But it's a great point. We'll definitely do that.
Sorry. Thanks. My name is Ani Ramesh. I'm a third-year medical student at Johns Hopkins. Over the last year of my rotations, I have met a lot of patients who are underserved. And even since the passage of the ACA, I still meet patients who are uninsured. And in some ways, it's good that, in one regard, that they get admitted to the hospital because they get plugged into social work. And social work works diligently at trying to get these patients insurance. But even then, that process can take weeks. And one patient I have in mind, she still is like MA pending, hasn't been able to get insurance. So I guess my question would be, what efforts are being made to reach out to the underserved population and help them actually access this new access to healthcare that they're supposed to have, especially considering that they have low health literacy and often low technical literacy and low literacy in general.
Well, this would be a good point, I think, for me to thank you profusely for what you're doing with the 1 Million campaign. Because what we've seen on, well, first of all, I should mention, I think primarily the community, the individuals you're talking about, are folks that the biggest opportunity they will have is when the exchanges start. And that begins in 2014. And in 2013, we together as a community are going to have enormous, enormous work to do to get people to be a part of that system. What we've learned, though, from the pieces that are already being put in place, how do we make sure a 23-year-old graduating from undergrad knows they can get on their parents' insurance? How do we make sure people know they have rights to preventative coverage as part of their insurance? People can't defend their rights if they don't know they have them. What we have learned over and over and over again is that for all the ink spilled in the Washington Post and the New York Times and all the panels they put on CNN, the number one way people know about what they got from the Affordable Care Act is one mom sitting next to another at a basketball game saying, you know, I just got my 23-year-old covered. Did you do that? It's one small business owner at that local Chamber of Commerce talking to the other about the tax credits. But where did that information start? It started from the small town hall meetings, from the small group gatherings that people like Doctors for America have been doing. I think sometimes those hallway conversations, those small round tables, that extra person you stop on the way out of the grocery store to pass this information on, those can seem like the extra things, the little things, but they are far and away the number one way that people know about what the Affordable Care Act has gotten them. So when it comes to what comes online in 2013 and 2014, we're going to have to take that, I think, to a whole nother level. What you guys are doing with the 1 Million campaign is one of the best examples I've seen any group do.
Hi, my name is Jamila Parrott. I'm the Medical Director of Planned Parenthood in Metropolitan Washington. And not surprisingly, I'd like to bring the conversation back to the subject. I thought that your comment about the grassroots movement, about the individual attention that was paid to women's health care at a state level, with the efforts to defund Planned Parenthood was a good point. My question to you really is how do we as OBGYNs engage other physicians in this conversation and make it clear that the issue is not pro-choice and anti-choice abortion or not to have an abortion, but really is comprehensive coverage for all women, whatever side of the argument that you fall for.
Oh, absolutely. Well, first of all, there's no better voice in this than yours. I think in this day and age where people are bombarded by information, they want to know not just what you're saying, but who's saying it. So as a medical professional, you come with a level of validation that most other advocacy groups don't have. And I think what I've observed is interesting. In this day and age, I think of Twitter, and I'm so glad you guys have a hashtag for the event, and online media, we sometimes think that that's what you have to do, that's all you have to do. What I've observed, it's interesting, it takes me back to my Peace Corps days. It's the power of the combination of the online with the in-person meeting. It's the power of bringing people together to talk about the difference you've been able to make in advocacy, convincing them to be part of it, and then giving them those online tools. And in your efforts to recruit others to be a part of this, I think one quick little observation I've made. I know oftentimes people say, well, does it really make a difference? If I add my voice as a medical professional, does one more person really matter? If you need any proof that this works, I point out the following. So when the President and HHS said that preventative care, including birth control, is covered by the Affordable Care Act, there were those in Congress who said, well, we're going to take that away. We're going to let any employer decide what they want to cover and what they don't. And both sides said they were going to do this. And the Senate had a vote on it. It was called the Blunt Amendment. You might have heard of it. And it failed. And I've never seen this happen this quickly before. One Senator, Lisa Murkowski, within a week of going back to Alaska, said she regretted her vote for it because she heard from so many local voices. And has everyone followed how that bill turned out in the House of Representatives?
Yes.
They didn't vote on it. They didn't vote on it because of what the furor they saw, the reaction to it that the Senate got. That's the first time that has happened with this Congress. And it wasn't because of what a bunch of people in DC were saying, it was because of what they were hearing in their districts. So if you need a story, if you need an example that that activity, that advocacy works, that's the best one I've seen all year.
Sorry, I was just going to say I think that it's definitely very effective. For people like me, though, who are residents of the District of Columbia, our voice means nothing. So we don't have anyone that's going to be able to vote on it. We don't have representation. So I just want to say.
Hi, my name is Ravi Parikh. I'm a medical student, and first of all, thank you for coming. But one thing I'm noticing is that there's a lot of excitement around ACOs, but it seems like there isn't a lot of specialist buy-in. And there's a real concern, I think, from a lot of specialists that they feel that this model is not good for their, not only like economic interests, but also for the patients, because they feel that they'll have stringent sort of requirements they have to feel. So I was wondering, what is being done for the buy-in to have more specialists be involved in ACOs? And how do you feel about just also expressing the viability of ACOs, because since the incentive is a shared saving bonus and a lot of specialists can still bill fee for service, how do you still see that would be like, a lot of them just don't have a buy-in, feeling that they feel like, oh, well, I'll just keep billing, say I'm billing, the way I'm billing, and it doesn't matter because the bonus won't be more than whatever I'm getting for capping people or taking out cataracts or, et cetera.
Yeah, that's a great question. So the first thing you should know about the accountable care organizations that we're testing at Medicare is that no patient is ever locked into that system. Patient choice continues to exist. So they don't need a referral to go to a specialist, for example. There is no gatekeeper function, I think, as people think back to what they didn't like about HMO days. Second, ACOs are not insurance companies. They are providers themselves. They are the clinicians. They are the clinicians needing to come together to decide to do this. And it's not for everyone, and it's not supposed to be in every organization and in every place in the country, but for the right integrated setting that makes sense for them. If you look at the successful systems that have essentially been accountable care organizations before we had the term, like the larger integrated systems, and you survey the specialists in terms of their job satisfaction and their reimbursement, they are more satisfied and as equally well reimbursed. So it's a bit of a myth that they're going to be less satisfied in this kind of system, or that they're going to lose out in reimbursement. Because you're right, they are still just able to bill in a fee-for-service system. But what happens here is the wraparound services around that specialty care are so much better. So repeat tests in particular are a thing that may go away. Readmissions, better care coordination for your chronic disease patients, and that actually makes the work for a lot of specialists a lot easier. And frankly, more interesting. So they get right to the more interesting pathology and clinical meat that they want to be doing, rather than doing some clerical work or some of that we all frankly do a lot of. And they're able to benefit from those additional services for their patients. So, we think that we're going to move in that direction, and I think specialists, yes, may be slower to come on board in certain places, but those that are in it and are practicing in those settings have been really satisfied and, like I said, and well reimbursed, and do know that the patient can always choose where to go and who to see.
Hi, my name is Natalie Neal, and I'm a medical student from Alaska, and I'm really kind of concerned about the issue of medical student debt as it relates to the primary care shortage. And personally, I'm going to have between $300,000 and $400,000 in debt when I graduate, and a lot of my classmates are in the same position. And I'm at the #1 primary care school in the country, but many of my classmates are just really concerned that they're not going to be able to make it in primary care. And so I know that the Affordable Care Act includes the expansion of the National Health Service Corps,
it's, this is, I think, this is becoming and is going to be in the coming years one of the biggest issues we're grappling with as a country, because as tuitions in places like Florida are going up 15%, and I'm talking beyond just medical school now, 15% a year, things are running out of control. The short answer to your question is no. What got done in the Affordable Care Act was a good start, but it's not enough. There's an opportunity we have literally right now to help bring awareness to this whole range of issues with student debt and to get something good done. Tomorrow, the President starts on a 2-day tour to talk about the fact that if Congress doesn't act by July 1st, Stafford loan interest rates are going to double. Right now, Stafford loans are 3.4%, subsidized by the federal government, because some would say making sure people can have affordable loans to go to school are a good idea that the government should do. If Congress doesn't act, they'll go to 6.8% on July 1st. Now, what I think the real contrast you'll see the President draw is, on one hand, we could keep student loan interest rates at 3.4%. The proposal on the Republican side is to give the average millionaire another $150,000 a year tax cut. That contrast is what he'll be driving. Now, will keeping Stafford loan interest rates at 3.4% solve everything? No. But it's one of those leading edge issues, just like the debate over birth control was a leading edge for a whole wider range of issues that allows you to get more people in the coalition, bring more people to the conversation. And I think if we win this one, it'll set the table for more work that needs to be done. But absolutely, I actually spoke to the National Health Corps a couple weeks ago, and I know right now it's oversubscribed, so we will definitely keep supporting that one. It's one good program.
My name is Elizabeth Salisbury. I'm a family physician living in Baltimore right now. And I actually have 2 questions. The first question is just, I was hoping that you might be able to talk a little bit about federally qualified health centers, community health centers, and where, if you've seen any good examples of where they're fitting into ACOs, because I know a lot, I work in an FQC in Baltimore, and a lot of people already have this feeling, well, okay, it's great, more people are going to Medicaid, but we already serve a really large portion of Medicaid patients, and our clinics need to be understaffed and underfunded and a bit chaotic as it is. And while we're glad to take on more patients, we're glad that patients are going to have Medicaid. I know that there's expansion, but I'm curious about if there are any new payment models or anything that might add additional support other than just giving us bigger centers and maybe being able to provide a few more doctors with the same current infrastructure. And then the second question is whether or not you've seen any innovative programs coming up that are actually going to potentially be addressing more than just coordination of care, but actually looking at underlying determinants of health. And whether that's education or poverty or community programming, advocacy. So I'd be interested to hear about both of those. Thank you.
Great. Thanks for the question. So first, on the FQHC side, so one of the programs that we launched at the Innovation Center was to support FQHCs in enhancing their services and essentially becoming patient-centered medical homes. So we're supporting somewhere around 600 federally qualified health centers across the country in their quest to be patient-centered medical homes. Now that wasn't exactly addressing your question, but at least as a first step in terms of support, new supports out there, both for on the IT side and on the some infrastructure build side that's coming from CMS directly. FQHCs as part of accountable care organizations is a longer conversation. One, because Medicare patients tend not to be at FQHCs as much, and the accountable care organizations, at least the way it was written in the legislation, rests on how many Medicare patients you serve. So that makes it difficult for any one FQHC or even a couple who band together to become accountable for a population of patients and their costs. But it's not impossible. It was actually really challenging for us at CMS to figure out the way we could actually map patients in the right way, but it's possible for FQHCs to band together, and usually it'll have to be probably figured out more than 3 would have to come together and say, we are going to pool our Medicare patients together in order to be able to do the types of things that you need to do and not take on risk, meaning that you risk losing money if things don't go correctly for you, but it's possible. And we're looking to support those opportunities at the Innovation Center. So we know that most accountable care organizations are going to have some sort of hospital involved in it, just because hospitals are where the capital is, it's where the infrastructure is. Usually that's where the electronic medical records are. It's just where they know how to float funds, they know how to raise capital. But we know that accountable care organizations can and should be different shapes and sizes. So at the Innovation Center, we're offering upfront infrastructure money for organizations that are not hospital-based that want to be accountable care organizations. So it's somewhere in the order of about $900,000, about $1 million, which is not a ton, but it's not chump change either, for organizations like at QHCs or other primary care or physician-led group practices that want to become accountable care organizations. They can apply for the money and put a hat in the ring to become accountable care organizations. So that was one. And then on the other side about the population health and what are we doing at CMS around those areas. This is a new area for CMS. We're a payer. We pay claims generally, right? You do something, you send us a bill, we pay it sometimes. So Dr. Berwick as the administrator actually was, I think, the one who really tried to get CMS to stretch beyond that and think about what is the health of populations and how can we as a payer support those. And so one of the things that we're doing with the Innovation Center and our funding, we put out a challenge grant to the entire country saying, what innovative ideas do you have out there? Throw it to us that you think can reduce cost, improve health, and improve care. And we got some really, really, really innovative and interesting responses. We actually got over 4,000 applications for about $1 billion in funding. So we obviously can't fund all of that, but you're going to see some really interesting, and they haven't been announced yet. Stay tuned next couple weeks. You're going to see some really interesting population health-based projects, which is really going to help CMS stretch beyond what we've done before. I can't say a whole lot more because the grants aren't out yet, but I think you'll like what you see.
So thank you for all the information in what you have been giving to us. My name is Dr. Murthy. I'm from Miami. In family practice for about 30 years. I do appreciate participating in CMS, providing these service for the Medicaid patients. Not only is a pleasure to be associated with CMS and any of the affiliated HMS, where I do not have a lot of restrictions. I don't need to worry about getting the referral consent and all of those things. But I do want to bring some restrictions what we have as a primary care. Just to give an example, one patient came in to see me with a acute exacerbation of chronic bronchitis, atrial fibrillation. So I need to examine the patient and do the cardiogram to see what is the rate of the atrial fibrillation, and also do the blood work and pulmonary function. My account executive comes in and says, okay, you cannot do cardiogram and the pulmonary function test at the same day and the same time because they will not pay. They will pay for one but not for the other. Still, I had to go and do that because patient needs it. So this is one of the restrictions what we have. If I send the same person to the hospital, the cost of the hospital care would be at least 10 to 50 times much higher. They would pay for all of those things. In addition to that, when we provide a physical therapy, for example, I practice integrated medicine, I heal the patient's pain without giving the medication. But if I bill the Medicare for physical therapy, even though I effectively treat the person, I get enough. I cannot do the ultrasounds in the office, but I would be forced to send the patient to another center where they will be paying the hospital at least 10 times more than. In a cost-effective area, what we are discussing here, I do not see the economics of this kind of a restriction on the private.
Well, thank you for that comment. And unfortunately too common that we hear about all of these types of examples where we're limited in giving services in a lower cost setting, and probably a setting that makes more sense for the patient. And so some of the ways that we're trying to address them in some of these new payment models, but it's slow, right? We're just testing them out now, which means the way the system exists is going to be as it is for a while longer. What I would say is to continue to bring those examples to an organization like this, and document as much as you can, because it helps shed light on all these inefficiencies and areas in which we can make improvements, and it really is helpful. So, I will take that back as just another example of something where we can make improvements. Thanks.
Hi, I'm co-partner.
As a family physician in Chicago, I teach healthcare reform for the family medicine clerkship, and each month the students come up with a lot of great questions. For one thing, they don't know what the healthcare system now is. So they don't know how all the different shifts and incentives fit within the larger picture. So laying out a concise and simple explanation of how the healthcare system is now is good for everyone who hasn't survived it to begin to piece together the pieces. There's a lot of different issues that do come up. I'm just going to run through a list. Fee for service is huge, trying to shift to paying to keep people healthy instead of paying for stuff. And the idea of if you keep people healthy, then you can still pay people the same amount maybe, but it evens out. You have healthier people. The insufficient primary care workforce is huge. Raising payments for primary care at the same time you're shifting to fee-for-service to try to shift towards a healthier population. Let's see what else. An emphasis on access to medical care instead of promoting health and wellness, what Elizabeth Salisbury had alluded to before. And then another big issue is with the EHR. Someone said there were 200 companies now with the electronic health records, but they don't talk to each other. And it's a huge source of insufficiencies that students and physicians complain about. That's the initial list. There's a lot of other issues within that, and I'm sure other folks can add.
That's a terrific list, and gosh, if we can fix those, it would be on our way. So we're trying to address actually all of them in some small way. I think the fee-for-service shift I talked about a little bit in how we're thinking about accountable care organizations. There are two programs. One of them stays in fee-for-service, and another one that we're testing moves us from fee-for-service to a partial capitation payment. So that means you're going to get a check cut to you from CMS at the beginning of the year, and that's what's going to cover their cost. It's going to be based on a very, very inflated, very generous budget. And again, patients will always have choice to go in and out, so we're not worried about, again, the gatekeeper issues. But again, that's our test to see, can we move large systems of docs and hospitals and all that comes with it out of the fee-for-service treadmill and over to a different type of payment. Man, it's a challenge. And it's a really important test that we're doing. We're testing it in 32 sites around the country. I think we're testing one in Chicago. I'll double check, but 5 in Boston, 3 in Detroit, 3 in San Francisco, 1 in Texas, 1 in Florida. They're everywhere. So I think this is going to be a lot of valuable information to teach us at CMS, can we move from fee-for-service open to something else. Oh, the insufficient primary care workforce. So I alluded to this comprehensive primary care work that we're trying to do, which is going to invest major dollars into primary care practices, but expect a lot out of those practices. And it's not just CMS that's going to make that investment. We're working with other payers, the Blue Crosses, WellPoint, Aetna, United, to all invest in the same way and ask for the same thing from a practice. If any of you who have worked with your private payers who, they ask you for some quality measures that are not the same ones that CMS asks you for, and they give you a care coordinator, but it's only for their patients, and it's only 10% of your patients, right? That doesn't really help you. So what we're trying to do is say, we want to get our act together on the payer side. We, CMS, along with all of the payers, so that your practice, the predominant of all of those who pay you, are going to ask for the same thing. So you can really transform your practice for all your patients. With that is going to, what we think will come about 30 to 40% more revenue for the practice. So 30% more revenue for a year, that's significant. Again, this is a test. And we know the pipeline is long, and even with an increase of even 30 to 40% reimbursement, there's a long pipeline to get out the other end to be a primary care doc. So we need to show positive change in that quickly, and we're going to try to do that as quickly as possible. And then lastly, on the EHR confusion, yeah, it's complicated out there. I was just at the American College of Physicians conference in New Orleans, and I wandered through the booths they have there. Wow. It's just like product after product. And you're right, we have a lot of work to do to get them to a place of usability where it's not just data going in, but it's actually data coming out, right? That's the important part, is what data can we get out of it to use in our clinical practice. And talking to each other and talking to different records is critical. So the next stage of meaningful use is going to come out soon. I actually don't know the timeline, but we know it's critical, and they're trying to get all of that moving in the right direction. But we definitely, I'll take it back, but we definitely know that there's a lot of confusion out there.
My name is Patrick Chimino. I'm from Tampa, Florida. I have the distinction of coming from the lead state in the constitutional challenge to the ACA, as well as the Republican National Convention. So, thank you. Don't forget Rob Scott. I have a couple of comments, and I don't want to sound critical, but the current system is very much predicated on the incentives that Medicare has placed, and everybody kind of that has been the sentinel to drive the healthcare system by and large in the United States. Now, the health system that I work with, I'm actually promoting EMR right now in independent practices, as well as the system chose not to get involved in an ACO. They chose to pursue a clinically integrated network, and it's going to be all with commercial insurers, so it's a baby form of change. But I guess the comments that I get I meet with a lot of physicians on both those fronts, and the comments I get from some of them say, and I'll give you a fact, it's a public fact, our health system has had the 2 best financial years ever. I know that's not the experience of a lot of people, but that's the way it is. The system's working for the health system financially right now. So they say, well, why is the health system even interested in changing? Which is, it's a paradox, quite frankly, and thank goodness there's a few insightful people in the upper leadership, because in general, it's not even it's not pervasive in the leadership. I think there's a lot of skepticism about change, because, hey, our system, it's working. We're making a margin. So the other thing I do get from a lot of physicians, we're trying to convince them to get involved in just a clinically integrated network. No risk. This is no risk for them. They're smart. They ask questions like, well, what are you going to do with the health system components that cost a lot of money? Are you all going to back off from that? I own a radiation center in my urology practice. What's going to happen with that? So and I think there are people who anticipate change is necessary, but there's a lot of resistance. This reinforcement system has worked very well, very well. I mean, it is very ingrained. So I'd just be curious what kind of, in the field, things aren't changing quickly. In fact, a lot of people are even sitting on their hands for EMR. And we're giving them money because of the safe harbor right now, and they're still sitting on their hands. So they're getting federal funds as well as health system funds. So, the system works for some people.
Thank you for those comments, and I encourage others, we really want to hear about the reality of what's going on around. I will tell you what I hear from some of the CEOs who are joining accountable care organizations, are telling their boards this is what we need to do, even in the face of saying potentially decrease reimbursement overall. And they say, one, it's the right thing to do, right? We can all think about doing better for the patient, and they say that's the right thing to do. This is going to be better care for the patients. That's great. But how do you explain that to your bondholders, right? So the way they talk about it is that we know that there is only so much that this pie of healthcare expenses can inflate. And at some point, it's just not going to inflate anymore. And they see the writing on the wall of that, and they want to get on board and trying out these new payment models. It might not be the exact one we end up in, but they want to, this is the time where there's a lot of incentives on the table. There's money for EHRs, there's upfront infrastructure payments for doctor practices who want to try out the ACO model. This is the time to experiment with having a care coordinator in your practice or really transforming. This is the time, because I think as we move on, we're going to have to move in that way just because the pie can't inflate any larger. And they say this is we have to change in order to survive. We can't dig in our heels if we want to survive. And so people have different perspectives on that, but a lot of the ones that have taken that leap, that they say my financial health is dependent on my ability to change now and take advantage of it now. And so I think you'll see those early adopters, and then as folks learn and we get more sophisticated, I think there'll be more products to help people move in that direction, and it'll become easier for certain systems to take on that risk. But it is, we know that the change is hard, and